Hi all, let's study the applied anatomy of brachial plexus. I am Dr. Komlayan, Professor, Department of Anatomy, Ramaya Medical College. All images and videos used in this presentation are from the textbooks of anatomy and various internet sources. The images are used for teaching learning activities only. The video is done to help the undergraduates understand the clinical anatomy. I completely acknowledge the ownership of the images and give entire credit to them. The objectives for today: we shall study about the clinical anatomy of brachial plexus, majorly the Erb's paralysis, clump case paralysis, winging of scapula, wrist drop and the claw hand. Anatomy of the brachial plexus, a quick recap. It's formed by the ventral rami C5 to T1. Sometimes there can be contributions from C4 and T2. These brachial plexus gives rise to the nerves that innervate the upper limb. The major parts of this plexus are roots, trunks, divisions and cords. Let's have a quick look at this diagram. You can see the roots here. As I told you, the roots are C5, C6, C7, C8 and T1. The C5 and the C6 joins to form the upper trunk. C7 forms the middle trunk. C8 and T1 forms the lower trunk. This is the upper trunk, middle trunk, lower trunk. Each of these trunks divides into ventral or anterior divisions, dorsal or posterior divisions. So these are the divisions. Ventral is represented by yellow, the dorsal is represented by the green. The ventral division of the upper trunk and the middle trunk will join to form the lateral cord. The ventral division of the lower trunk continues as the medial cord. The posterior divisions or the dorsal divisions of all the three trunks will unite to form the posterior cords. So these are the cords of the brachial plexus. This is the lateral cord, this is the posterior cord, this is the medial cord. Now coming to the branches, lateral cord gives off the lateral pectoral nerve, lateral root of median nerve and musculocutaneous nerve. Medial cord gives off medial pectoral, medial cutaneous nerves of the arm and the forearm, the ulnar nerve, the medial root of the median nerve. The median nerve receives twigs from both the lateral cord and the medial cord. Branches of the posterior cord: upper subscapular, lower subscapular, nerve to latissimus dorsi, the axillary, and the continuation of the posterior cord is the radial nerve here. The branches from the roots of the brachial plexus are dorsal scapular nerve and the long thoracic nerve. Dorsal scapular nerve, the root value is C5. It supplies the rhomboids and the levator scapulae. The other nerve from the roots is the long thoracic nerve with the root value C5, C6 and C7. The long thoracic nerve will supply the serratus anterior. Here is a case of winging of scapula. A 20-year-old boy presented with discomfort and weakness of the right upper limb over the past 2 days. He complains of vague discomfort in the posterior shoulder. He had vigorous routine of weightlifting during the last month. Physical examination revealed a prominent medial border of the right scapula. Nerve to serratus anterior is the long thoracic nerve, and injury to this nerve will cause excessive prominence of the medial border of the scapula. You can see in this picture the medial border and the inferior angle of the scapula is elevated and more pronounced. There is a test called as wall test. If we ask the patient to stand against the wall and do pushing or punching movements, the medial border is more prominent. This confirms the injury to the long thoracic nerve and the serratus anterior. Coming to the injury to the upper trunk, we shall now look at the case. A newborn was noticed to have abnormal arm positions, lack of movements of the arm, with diminished sensation and poor grip strength. Parents gave a history of prolonged labor and forceps delivery. Upper trunk was formed by the C5-C6 roots. This is the Erb's point. Erb's point is nothing but the junction of C5-C6, suprascapular nerve, nerve to subclavius, and the two divisions of the upper trunk. If there is injury to the Erb's point, the axillary nerve, suprascapular nerve, musculocutaneous nerves are all damaged, resulting in this position of the hand. This is known as the waiter's tip position or the policeman's tip hand. More details about Erb's paralysis, refer to my video done specifically for the Erb's paralysis. Coming to the injury of the lower trunk, this can result from excessive abduction of the arm during labor or when a person falls from a height grasping something to save himself. Whenever there is an injury to the lower trunk, C8 and T1 are involved, leading to clump case paralysis. Here is a case. 4-month-old infant presented with complete paralysis of digital flexors and intrinsic muscles of the hand. Symptoms of Horner syndrome were noted. Delivery was by emergency cesarean section. Birth records revealed that there was difficulty during delivery. So this is a clear case of clump case paralysis where there is damage to C8 and T1. In such cases, there is injury to ulnar nerve and the median nerve. Because of injury to these two nerves, the motor loss of all intrinsic muscles of the hand is seen. The lumbricals, normal action of lumbricals are flexion at the metacarpophalangeal joint and extension at the interphalangeal joint. But due to the injury to the ulnar nerve and the median nerve, there is loss of action of this lumbricals. Instead, there is a reverse action where there is extension at the metacarpophalangeal joints and flexion at the interphalangeal joints. Because both the nerves are involved, that's the median and the ulnar, there is a complete claw hand. In clump case paralysis or injury to the lower trunk, T1 is also involved. Because of the involvement of the T1, the sympathetic fibers gets affected, leading to Horner syndrome. Coming to the lesions of the cords, whenever there is damage to the lateral cord, the musculocutaneous nerve, median nerve are damaged. In such cases, there is paralysis of the muscles like biceps brachialis and coracobrachialis, and because of the paralysis of these muscles, there is difficulty or flexion of the elbow. Lesion to the medial cord can cause weakness of muscles innervated by the ulnar nerve. It also results in the sensory loss in the medial arm, medial forearm and hand. Lesions of the posterior cord can cause damage to the subscapular nerve, thoracodorsal nerve, axillary nerve injury, radial nerve injury, etc. Paralysis or the weakness of the subscapular nerve can affect teres major and subscapularis. Thoracodorsal nerve palsy results in defective latissimus dorsi. Axillary nerve injury affects the deltoid and the teres minor muscles. Radial nerve injury can affect extension of the elbow and the wrist. There can be sensory loss of the extensor surface of the arm, forearm, back of hand and dorsum of the fingers. If there is injury to the surgical neck of the humerus, commonly the axillary nerve is damaged. A man with poorly fitted crutches can lead to the injury to the radial nerve. Also, when a man is falling asleep with his arm hanging over the armrest of the chair can also compress the radial nerve. So either due to the Saturday night palsy or due to the poorly fitted crutches, the radial nerve can get damaged, leading to a condition called as wrist drop. In this case, all the extensor muscles of the forearm are damaged due to the involvement of the posterior interosseous nerve. Hence, there is unopposed actions of the flexors leading to wrist drop. Thank you all.